Now we will be moving on to topic 2, and in this particular one we're going to be talking about refractory obstetric APS, starting with defining precisely what refractory obstetric APS actually is in greater detail. It is the presence of recurrent obstetric comorbidity despite appropriate treatment with low-dose aspirin and prophylactic heparin. So, is refractory obstetric APS a problem? Well, I believe it is, because up to 20-30% of patients with APS will experience refractoriness. As we've seen in the classification criteria, there have been some changes in the obstetric domain, both in the definition of fetal death and in the distinction between fetal death with or without preeclampsia or placental insufficiency. And this seems to result in poorer classification of patients with obstetric APS. In this section, we will review the pathogenesis of APS and the role of the different treatments in this disease. The placenta is a key organ in APS. We know that the main antigen, which is known to be recognized by antiphospholipid antibodies, is beta-2 glycoprotein I, and this antigen is highly expressed in the human body and other related tissues, including the human placenta. Both thrombotic and non-thrombotic mechanisms, including inflammation and complement activation, act on both sides of the placenta. Among the histological findings in placentas from patients with APS, notable features include the presence of infarcts, abnormalities in the spiral arteries, and even accumulation of complement split products. Antiphospholipid antibodies act on the trophoblast, impairing its ability to invade. And also on the decidual cells themselves, promoting an inflammatory phenotype in these cells. All of this hinders the connection between the spiral arteries and the trophoblast and ultimately leads to placentation defects that result in early miscarriages. Additionally, I also just want to mention that although the stratification of the high-risk antibody profile can be applied to patients with SADI, this is not the case for the low-risk profile, as it is not. In reality, these patients would have a higher risk than what that antibody profile would suggest. Regarding hydroxychloroquine, as for its mechanism of action, we all know that it is fundamentally immunomodulatory, but it also has other mechanisms, such as anti-inflammatory and antithrombotic effects, which make it a particularly interesting drug for this disease. Let us remember that it is a safe drug both during pregnancy and breastfeeding. Studies have shown that it prevents fetal death and placental insufficiency by counteracting the effects of antiphospholipid antibodies, and it even prevents abnormal development of the fetal brain. A retrospective study published in 2021 focused on patients with primary refractory obstetric APS. It was observed that the live birth rate in patients who received 400 milliliter of hydroxychloroquine daily in addition to standard treatment was higher, as you can see, 97% compared to 62.5% in patients who did not receive it. Currently, there are 3 clinical trials underway investigating the role of hydroxychloroquine in obstetric APS, and they will surely yield results that will be useful. As for glucocorticoids, in this case, the evidence is more limited. Still, the recommendation is cautious, considering the use of prednisolone at low doses during the first trimester in refractory cases. And this recommendation is based on a study published in 2011, which included patients with obstetric APS who had experienced at least 1 miscarriage despite standard treatment. In this case, they used a dose of 10 milligrams of prednisolone per day until week 14. And the reason they use this form of corticosteroid is because it has the lowest transplacental passage. In this case, the live birth rate was 61%, which is considered relatively high with this drug, although there were 5 complications, including preeclampsia, preterm births, and small for gestational age infants. Another study, published more recently in 2022 and conducted here in Spain, also evaluated the role of glucocorticoids in refractory obstetric APS. In this case, they included women with obstetric APS who had experienced at least 2 miscarriages, although it was not specified whether they had received prior treatment. In this case, they used a different corticosteroid regimen, methylprednisolone, up to week 12, followed by a gradual dose reduction. In this case, they observed that the miscarriage rate decreased in patients who received corticosteroids, and it was 38.5% compared to 85% in untreated patients. As for intravenous immunoglobulins, in this case it would be considered a second-line treatment, and the mechanism of action would be to neutralize circulating antibodies. We know that it is a product that crosses the placenta, but it appears to be safe for the fetus, and it seems in retrospective observational studies that it improves the live birth rate in refractory cases. However, in clinical trials, its effectiveness has not been definitively and conclusively proven. In addition, a study published in the year 2008 on patients with refractory obstetric APS who received immunoglobulins found that the live birth rate was notably high, reaching an impressive 83.7%. Furthermore, it is important to note that the dose they used was a relatively low dose of 0.2 grams per kilogram every 4 weeks. Moreover, and just to give us an idea, in inflammatory myopathies, the dose is 10 times higher. It's 10 grams per kilogram. And although the live birth rate was high, they did not find any differences. And in 2024, a clinical trial was published, which is the first clinical trial using immunoglobulins in refractory aesthetic SAP. It is a multi-center, open-label, single-arm trial, therefore, without a comparison group in which a single cycle of immunoglobulins is used. In this case, if we add up the dose, it does amount to 2 grams per kilogram, but distributed over 5 days. And this dose was administered after detecting the first fetal heartbeat. Additionally, the protocol allowed the use of other treatments, including rituximab and pravastatin, but did not allow the use of hydroxychloroquine. And the primary outcome variable was the live birth rate at week 30. However, the results they obtained were not very positive. There were only 2 live births after week 30, although they mentioned that 60% of the patients showed improved obstetric outcomes compared to previous pregnancies. This study has many limitations. It has a very small sample size and no comparison group. Additionally, the use of certain other drugs also potentially introduces bias. But, well, indeed, it's the first trial, and in some refractory cases it could be considered